Good evening, everyone. My topic for presentation today is phacoemulsification in a patient with age-related cataract and poor endothelial count. Introduction: in healthy eyes, phacoemulsification decreases endothelial cell density by 1.8 to 15%. Endothelial cell loss in an already compromised cornea can lead to further decompensation. Hence, it is very important to evaluate it. Clinically, endothelial damage can be presented by corneal edema from mild, which is shown in the image, to bullous keratopathy. In the image, we can see epithelial bullae along with stromal edema. That is why we need to look out for patients who are at risk of pseudophakic bullous keratopathy, and the patient-related challenges we need to look out for, which are as follows. First is advancing age. As we all know, endothelial cell physiologically is reduced in a normal aging eye. But in case of decompensation, it is compensated with pleomorphism and polymegathism. Second is the density of the nucleus cataract. The denser the nucleus cataract, more ultrasound energy will be required in case of phacoemulsification. Hence, the nucleus grading should be evaluated properly. Then corneal getae should be looked out with careful slit lamp examination, because they are known to cause endothelial dysfunction. In case of shallow anterior chamber, we know that the tip to the anterior chamber, the distance is lower. That is why whatever the phacoemulsification energy will be, ultrasound energy will be used, it will be transferred to the endothelium indirectly. Glaucoma-induced endotheliopathy are also well-known cause of endothelial cell dysfunction. Then we need to properly evaluate history of endothelitis and uveitis. And diabetes mellitus and systemic conditions are a well-known cause of endothelial count less and dysfunction. Now let us take a case scenario. There is a 64-year-old man with a history of diabetes mellitus. He complains of blurring of vision. On examination, we see a nucleus grading, sclerotic grading 3 cataract along with shallow anterior chamber. So how will we approach this case? First, preoperatively, careful history and examination needs to be done. Whatever we've discussed just now, all those challenges, properly history and anterior as well as posterior examination needs to be done. Second, specular microscopy needs to be done, in which the qualitative and quantitative condition of the corneal endothelium will be noted down. Now, intraoperatively, what are the phacoemulsification techniques or things that we need to do? First, viscoat should be ready. Tri-soft shell technique can be used in these cases because it is known to be cornea protective, endothelium protective. Maintain AC deep and stable all the time. This can be done by adjusting the bottle height. Keep emulsification within the circumference of the safe zone, which is shown in the picture below. So this is the safe zone, and we have to keep our emulsification within this area, which is away from the posterior capsule, away from the endothelium, and away from the anterior capsular angle. The chopping technique that can be used is direct chop. It requires mechanical forces more. That is why less ultrasound energy is used. The nucleus can be eaten in the capsular bag or at the level of the pupillary plane. Minimal energy to be used, and use torsional phaco if possible. Avoid tumbling and bouncing of the nuclear fragments in the anterior chamber. Keep IOP normal to low. Intracameral drugs, preferably preservative-free, should be injected under air. Post-operative care, start the use of corticosteroids to minimize post-operative inflammation to help survival of the endothelium. Lastly, and very important, counsel and discuss risks and complications with the patient and the family, and take a proper decision before taking the surgery. Thank you.
Dr. Arnika, you can unshare the screen and answer the questions. Yeah.
Yes, ma'am.
Yeah, Dr. Arnika, that was a very comprehensive presentation.
Thank you, sir.
So I wanted to know, what is viscoat?
Sir, viscoat is a dispersive viscoelastic device, which is used to protect basically the corneal endothelium, sir.
Okay. So what's the constitution of viscoat?
So sodium hyaluronate and sodium chondroitin sulfate.
So which is the important one here?
Sir, sodium hyaluronate protects the corneal endothelium, and the chondroitin sulfate forms the AC, anterior chamber.
Okay. So it's the other way around.
Sorry,
Chondroitin sulfate is negatively charged, so it goes and hits the endothelium,
anterior.
and sodium hyaluronate is space maintained. Okay. And what is the full form of OVD?
Ocular viscoelastic device.
No. It's ophthalmic viscosurgical devices because it's a surgical tool. It's not just a jelly, it has surgical role. So it's very important. You explained soft shell technique, but can you elaborate on how soft shell technique is done?
Yes, so first we inject dispersive OVD. Then after that, we inject the Helon 5, sir, that is the viscoadaptive. So because of that, the dispersive cohesive, the OVD will go and coat the endothelium. Beneath that, we have to inject the BSS solution, which will be in the third layer. So third layer will be, yes, sir.
Okay, good. And who described this technique? Whose technique is it? Dr. Steve Arshinoff.
Steve Arshinoff, sir. Yes.
Yeah. So this is the landmark presentation for this. The second thing I wanted to ask is, you mentioned about post-operative counseling that the patient might, decompensate. So, I mean, that's an important point, but I think what's more relevant to understand is the problem is already there in the patient's eye. So would you want to do a post-operative counseling or a pre-operative counseling of?
No, actually, sir, that counseling was like pre-operative counseling only. That main I wanted to highlight was that counseling is a very important thing before, as well as taking with the family, as well as with the family patient as well. It is pre-operatively only, sir.
And you discussed about phaco and the fact that you should be operating at the iris plane or at a lower plane. But do you think parameters have a role to play?
Yes, sir.
Because it's, I mean, you can have 100% phaco energy running, in a continuous mode, and even if you do it any distance away, you're going to burn the endothelium.
Yes, sir.
So so during the surgery, because that's what you said, phacoemulsification. So I wanted to listen to intraoperative performance. So which, according to you, which mode of energy delivery would be the best?
So basically, less of ultrasound energy, so more of vacuum generated energy we need to use, sir.
Vacuum will cause you occlusion break surges, because the moment you break vacuum, you will have a surge. So what I was looking for is interrupted energy, rather than continuous energy, sir. And preferably torsional, because there's no loss of energy when you're having the chatter.
Yes, sir.
One more important point is, after every 2 quadrants, you want to top up the viscoat, because it's already washed out because of the fluidics. So, doing a viscoelastic insertion, viscosurgical device insertion between every 2 or 3, quadrants would be a good preservative,
Yes, sir.
endothelium. Okay. All right. That's all at my end.
Thank you, sir.
Ideally, as I was telling everyone, it should not have been like viscot. It's as somebody said, it is the chondroitin sulfate that is going to protect the endothelium.
Yes, sir.
So if that is the one that is going to protect the endothelium, why don't you actually fill the anterior chamber with that and do it?
So AC won't be maintained because of that.
AC will be maintained.
So we'll have to repeatedly put. That is why.
No, it is very difficult to. It is much easier to take.
Actually, more difficult to take it out, sir. Maybe that is why.
No. So what happens is, if we see, we have all this higher end phacoemulsification. Why do you go for the higher end phacoemulsification? Like Dr. Samresh said, like you have the different modes of energy delivery. You have pulse, micropulse. I mean, lot of variations are there where you have energy going, then stopping. There is where there is no energy being delivered, so it has got a cooling time happening. So with these, you don't expect the what happens if there's more of energy being used.
So it is indirectly being transmitted to endothelium, sir.
See, more than the energy. See, in these hard cataracts, it's a chatter that happens because it's hard, small nucleus bed that just goes and hits the endothelium. So the chondroitin sulfate is actually protecting the endothelium. Okay, that is fine, and with whatever energy modulations and techniques, you can protect it. But with higher energy that is happening, there is another risk that is there. That is wound burn can happen.
Yes,
You
sir.
have the more energy wound, so you have the sleep to protect it, but still. So what happens if it is full of conductive sulfate? Is that it's very thick. It blocks those pathways. Okay, it might be in the tip or where. So the energy, the tip gets occluded, and the energy buildup happens.
Okay.
So you have the chance of wound burn much higher if you actually fill it fully. So always you protect it with the endothelium or whatever. Helon or even normal viscoelastic HPMC, whatever you use underneath it, so that you don't get that wound burn. Another question. So, is there? See, you told about counseling. What are you going to tell in the counseling? See, what is the choice that you're going to give the patient?
What are
See,
the
add endothelium, and you have a hard cataract. So, what is the other choice that you're going to give the patient during counseling?
Okay, so basically, first we all have to look out for the specular microscopy values, like what is the endothelial cell density?
Is poor.
Is how much, sir?
Specular is 4,500 or
Okay,
1,000.
if specular microscopy is normal, sir, then we
No.
have to
1,000 is 1,500 normal.
1,500. Sorry, I heard sir 3,500.
Okay, 1,500 or lower. So
1,500 or more. So basically, sir, we have to counsel the patient that since the endothelial count is low, whatever the complications that can occur, like for example, sir, bullous keratopathy, and according to that, we have to tell about the options that we can give to the patient.
Yeah, I understand. That is after surgery. So before surgery, what is the you can tell them, okay, there is another option available. Like it's,
Yes,
it's
sir.
quite what is the other option that you? I mean, at least you should tell the patient because it's quite bad, like quite below of bad. But the cornea is okay as of, but you on slit lamp and specula, you know that it's quite a bad thing. What is the other option?
So
that
keratoplasty, DSEC, or this we can do it either cataract alone or combined, or we can do it as a staged operation, sir.
Okay, that's something, an option that you're going to give the patient. So some endothelial DMEC or whatever.
Yes, sir.
Okay, so that should be part of your counseling. So explain the complications is one, giving an option for this also another one.
Yes, sir.
So theoretically, what is there any of the topical drops that can actually? I mean, some studies have shown that it actually helps in these cases with poor endothelium, which are undergoing cataract surgery. Post-operative use of these medications might actually help.
Sir, Rho kinase inhibitors like ripasudil.
Yeah. So what? Just one question on netasudil. So what is one of the problems that can happen with? Just tell me two problems that you can get with Rho kinase inhibitors. Okay, post-operatively, you can have, but though because you're using steroids, it might not be there. The congestion, the red eye
Yes,
is a thing, and you can get the honeycombing of the cornea. See, you might have conjunctivitis, but that's a deposition. What happens in this honeycombing is that, see, the it's sort of like endothelium is pushing out fluid, but it is actually pushing it onto the epithelial side. So those honeycombing sort of an appearance can happen, and it doesn't affect vision, but it looks bad on. But once you stop it, it goes. So these are the one. And when you're talking about the counseling, not just complication, the other option that you're going to give, and it's better not to use the trade names while you're presenting.
Okay, sir.
And as Dr. Samaresh said, you should know what protects and what maintains.
Yes, sir.
Okay. Good presentation. Thank you.
Dr. Ankita, just one before we wind up and go to the next speaker.
Yes, sir.
Can I do SICS?
Yes, sir. If it is a dense cataract, we can do SICS, sir.
Mhm. So can you enlighten us about any studies which have compared the SICS with phaco and any outcomes on the endothelial counts and all that?
Mm,
Did you come across anything like that?
so I'm not very sure, sir.
Okay. Maybe that's
Thank
little studies that we can
Yes,
do.
sir.
There have been a lot of studies where they've compared the endothelial cell count after SICS and vis-a-vis with the phaco.
Yes, sir.
That will be an interesting study if we can take a look. Okay.
Yes, sir.
Good.
I'll make
Very
a
good.
Thank you,
Thank
sir.
you.